Good day. We'll be discussing examination of the chest. And how do we go about that? Examination of the chest is we have to talk about the inspection, palpation, percussion, and auscultation. For before we start, we want to create a rapport with our patients or our simulator. We want to seek for permission. We sanitize our hand and also screen the patients. What are the things we are going to check us for under inspection? First and foremost, we want to make sure that our patient lies down flat, and we check if there is any respiratory distress still under inspection. We check if there is any thoracostomy scar for patients that have had lung surgeries before or thoracic surgeries before. Then also for patients that have condition that procedure that is called bullectomy before. Then you also want to look around the patients. On the table of the patients, we have inhalers on the table of the patients. We also have to put some milk. Is the patient on oxygen? So all these things are very important when we are trying to examine a patient that has a respiratory system condition. Now, that's for inspection. For palpation, we want to start first and foremost with the respiratory rates of the patient. And what we are going to do is that we will be seeing the stress in our patients by checking for the pulse of the patients. So we'll be seeing, but in the real sense of which we are trying to check for the respiratory system of the patient. So you just hold the patient as if you're checking for the pulse so that the patient will not be overly agitated. So that's for respiratory rate. Still under palpation still, we want to check for the trachea. If the trachea is deviated, if it is central. And that's this how you're going to go about it. You are going to use 3 fingers, the index finger, the middle finger, and the ring finger. So the 3 of them will be placed around where the trachea is. The index finger will be on the lateral border, the right lateral border of the clavicle, while the ring finger will be on the left lateral medial border. Sorry, there's a mix up. The index finger will be on the right medial border of the clavicle, while the ring finger will be on the left medial border of the clavicle, and use the middle finger to stroke down the trachea. So you use this to stroke down the trachea. Then you check, you dip in your hand. Then also dip in your hand. You dip in your hand, you dip in your hand bilaterally to check if one part is deeper than another. The part that is deeper, that's where the trachea is deviated from. The part that is deeper is where the trachea is deviated from. So what am I saying? If this part is deeper, it means that the trachea has been pulled away from this side. So that's for trachea deviation. Then before you leave around the neck region, you also want to do what is called the cricothyroid distance. Normal cricothyroid distance is around 6 centimeters. So you put your hand, so you check the thyroid cartilage. Then just below is where the cricoid cartilage is. Use 3 finger breadths. So to check. So we have this about 6 to 7 centimeters. For situations like COPD, chronic obstructive pulmonary disease, where the lungs are hyperinflated, the cricothyroid distance is usually around 3 or even 2 centimeters or 3 centimeters. Highest maximum is 4 centimeters. That's for the cricothyroid distance. Before you leave the palpation, under palpation for respiratory system examination or chest examination, you do what is called the chest expansion. Chest expansion, you place both thumb on the chest, then you tell your patient to breathe in and out. Can you please breathe in? Okay. So normal chest expansion, the distance between the chest expansion is 2 inches or 5 centimeters. You go to the upper parts, the middle parts, and the inferior parts. So the upper parts just above the nipples, then the inferior part, the middle part just below the nipples, and then the inferior parts just around the coastal the costovertebral region of the anterior part of the chest. Another thing you want to do is that you want to check for the anterior, posterior, and lateral diameter in order to ascertain if that individual has a barrel-shaped chest or not. This is what you are going to do. Can you please lift your back a bit? Your back. So just you measure at the level of the nipple. Okay. Using your inches side so that you won't be biased. So here we have 84. That's for anterior posterior diameter. Then I also want to check what is called the lateral diameter. So lateral diameter is just for the right. Raise your back again. Just from the middle part of the back to the middle part of the chest. So here we have 41. 41. The ratio shouldn't go beyond 0.5 or 0.7. By the time you start having the lateral over anterior posterior diameter ratio going to above 0.7, that is in keeping with barrel shaped chest. That's for still under palpation. However, still under palpation, once you check for what is called the tactile fremitors. So you tell your patient in the language he or she understands. If he's an educated man like a simulator, you can tell him to say 99 or 99. Can you please say 99?
99. 99. 99. 99. 99. 99.
Okay. So that's for the tactile fremitors. And what does tactile fremitors mean? If you have some situation like pleural effusion, the tactile fremitors is reduced. If you have some situations like consolidation, maybe lung cancer, pneumonia, some recessive lung diseases, the tactile fremitors is increased. However, in situations like maybe COPD, the tactile fremitors might be normal or also reduced. Before I go further, the principle behind tracheal deviation is that the trachea is deviated to the side that the pressure is lesser. The trachea is deviated to the side that the pressure is lesser. For instance, now, if there is pleural effusion on the left, the trachea deviated to the right because on the right, the pressure is lesser on the right. If, for instance, now, if there is pulmonary fibrosis on the left, the trachea will move to that side because where there's pulmonary fibrosis, the pressure there is lesser. There's lung collapse, the lung is smaller, so the pressure there will be lesser. However, when we are done with that, we want to percuss the patient. So we run over to percussion. Before you start percussing, you want to ask your patient if there's any pain around the chest. Do you have any pain on your chest? Okay. So you can percuss the clavicle first. Then you put your hand at the intercostal space. You percuss. Okay. So that's how you go about this. Then you percuss laterally too. Two sides. Okay. Now, when you are done, you want to do what is called auscultation. So auscultation, you check for the breath sound and the vocal resonance. For auscultation, you start from the apex beats, from the apex of the lungs. Bring in the nose. Bring in the nose. Okay, bring in the nose. Okay. 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 So when you are done, so when you are done with listening to the breath sound, you check what is called the vocal fremitors. Just like when patient verbalizes the 99 and you tell him or her, then you listen over the stethoscope. That feels nice. Whenever this touches your chest, you say nice, okay?
99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99.
So that's this for the anterior part of the chest. Then if you're efficient to sit up and check the posterior part of the chest, have to sit up. Can you do like this? So I tell patients to fold their arms. And the reason is because the back will be very obvious. The scapula will move towards the lateral part of the back. That's why I want to tell the patients to fold their arm. So you can see the scapula has moved laterally. Before you start touching your patient's back, you want to also do IPD also. You want to check once it's fit. So check for thoracotomy scar, just for any form of scar around the back of the patient. And after that, you go straight to the fremitors, which is starter fremitors. Can you please say 99?
99, 99, 99, 99, 99, 99, 99, 99.
Yeah. So do add Pacos. Is remember that you don't purpose over the bone inconvenience. You never need to use it. Always start your examination from your side. Oof. So I want to touch your perfectly in 70.
99, 99, 99, 99, 99, 99, 99, 99.
That's all. Now I will have to examine him immediately. So I have to run commitment to sign up. And I have to run commentary. So I will demonstrate the examination and see is an exact setting. Good afternoon. I'm Dr. Adeleke. I want to do a chest examination. I have to sit. Thank you very much. So I want to sanitize the element. And I also want to spray my patients. The patient respiratory rates is 16 cycles per minute. There is not fracture deviation. See critical thyroid, the critical standard distance is 6 centimeters. Science to back, please thank you. to fit it at any point is that was then in life. I think I mean, trees and that.
Oh, nice. Yes, I.
So the anterior posterior diameter of the patient is 84 centimeter, while the lateral diameter of the patient chest is 42 centimeter. So that's the ratio is about 0.5. Patient does not have a barrel-shaped chest. So please, I want to place my hand on your chest. Whenever I place my hand on your chest, I place it like tonight, okay?
Light to light. Light to light. Light to light. Light to left. It's right to left. Right to left.
So I place it like this. Your hand goes like this.
Light to left. Light to left. Light to left. Light to left.
Is there any good to spinning? So patient's pattern phrenicles is normal. His percussion loss is resonance with the preservation of cardiac and hepatic dullness. Thank you very much. So whenever this touches your chest, you bring it up, okay? I'll store means is that hard to say next one.
Light to left. 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 Light to left.
His right side is vesicular and it has normal vocal resonance. Sit up. Thank you. Great. It's your hands together like this. I can just hold the hands. Okay. Thank you. On examination of the posterior parts of the chest, there is no thoracostomy scar and there is no any obvious deformity or findings. Can you say myself whenever I touch you?
Nine.
With someone like this, oh,
Yes.
they give you a patience.
And you can ask. All right, ma. So I would like to ask, what are the different examination findings you can see in different lung conditions?
Okay. Thank you very much for your question. Starting with inspection, if you see that your patient is in respiratory distress, almost all pulmonary conditions can cause respiratory distress. Now, when it goes to the respiratory rates of the patients, if the patient has radius to the left because the pressure there is lesser. If you have a patient that has lung fibrosis, a patient that has atelectasis, a patient that has lung collapse, the tracker will be dedicated to that side because the lung volume is reduced, the pressure there is lesser. Now, if you have a patient that has reduced cricothyroid distance, A patient that has hyperflated lung, the cricosternal distance will be reduced. If you have a patient that has reduced chest expansion, a patient that has consolidation like pneumonia, especially lobar pneumonia, the chest expansion on that side will be reduced. Now, what about the tactile fremitors? For consolidations in general, tactile fremitors usually increase. What are the conditions that can cause consolidation? We have pneumonias, bronchopneumonias, lobar pneumonias, conditions like suppurative lung diseases, empyema thoracis, bronchiectasis, lung abscess. We have conditions like bronchogenic carcinoma, mesothelioma, restrictive lung diseases in general can cause increased tactile fremitors. And in what condition can we have reduced tactile fremitors? Conditions like pleural effusion can cause reduced tactile fremitors on the affected site. What about condition that can lead to percussion, different forms of and types of percussion notes that we have? We can have percussion notes can be door, it can be resonance, it can be stony door, and it can be hyperresonance. Door percussion consolidations in general, tuberculosis, pneumonia, and so on and so forth, can cause door percussion on the affected side. Now, hyperresonance percussion is in keeping with COPD. And how are you going to differentiate this? You just how are you going to realize this when you're percussing the patient's chest? It should be as if you are percussing over an empty drum, and there will be loss of cardiac and hepatic dullness for hyperresonance percussion. Then for stony door percussion, condition like pleural effusion commonly causes stony door percussion. So it will be as if you are percussing over a stone. Now, when you get to the breath sound, what type of breath sound can the patient have? The breath sound can be vesicular, breath sound can be bronchial, breath sound can be bronchovesicular, breath sound can be um, it can be bronchial. Now, for vesicular breath sound is normal physiologic breath sound. That is vesicular breath sound. For bronchial breath sound, we have conditions like pneumonia, we have conditions like tuberculosis. In fact, bronchial breath sound is even divided into like 3 or 4. We have tubulous bronchial breath sound, we have cavernous bronchial breath sound, we have amphoric bronchial breath sound, we also have scordiac bronchial breath sound. And what does this scordiac mean? It means when there is the junction, if a patient has pleural effusion, the junction between the air and the fluid, when you listen around that side, it is called the scordiac breath sound. For patients that have cavitatory pulmonary tuberculosis, the type of bronchial breath sound we hear is what is called amphoric breath sound. It will be as if you are blowing air into an empty bottle. What about so for pneumonia and some other causes of consolidation, we can have cavernous or tubulous breath sound. Now, for bronchovesicular, it can either go either way, maybe for patient that has maybe pneumonia also, or even empyema thoracic, depending on what's the stage of at which you are picking the patients. What are some of the other sounds that you can hear in a patient that has a respiratory pathology? A patient that has aspiration, we hear what is called transmitted sound. That's what you are going to hear, transmitted sound for a patient that has aspiration. Then you can also hear what is called ronchi. Ronchi is like wheezing on auscultation, so it's like a musical sound on expiration, so you can hear ronchi. You can also hear what is called stridor, inspirative stridor. When you listen over your stethoscope, you can hear stridor so you can hear stridor without your stethoscope, and you can also hear it with your stethoscope. You can also have crepitation. Crepitation means when there is fluid mixed with air. You can have crepitation, which can be coarse or fine crepitation. Coarse crepitation is found in 2 common conditions: in acute pulmonary edema or in pneumonia that is resolving. Pneumonia that is resolving, broken pneumonia that is resolving. Why fine crepitation is found in pneumonia that is just starting? Fine crepitation is for pneumonia that is just starting. Then some other others that we can also have. Okay, I think those are basically the ones that we have. So those are different.
All right, ma. Thank you, ma.
Yeah, welcome.
Free audio post production by alphonic.com.